And we evaluated the organs from the stomach. We looked at the pancreatic body. The duct was normal. In the neck, it was normal. There's some CBD wall enhancement. There's no stent currently. And we saw some intrahepatic stones, actually, which we'll show you in a minute. And Dr. Junaid just got into the second portion of the duodenum and is now completing his evaluating from the second portion. So from the above, we were able to see most of the head of the pancreas, but the uncinate is oftentimes not well visualized. So we're going to look at the uncinate and the rest of the pancreas. So what do you see here?
I think that's Hotta.
Okay.
Is that so?
I can't tell, to be honest. If you think it's aorta, usually you want to go clockwise for the pancreas. What do you think is above it, though? Where's cursor?
Sorry, Mustafa.
Yes.
Can we have Doppler?
Yeah. इसको हटाना यार फिर से ये that looks here. I'm not sure why we're not seeing the waveform, but anyway, we don't. I mean, honestly,
You are in the bulb, right?
yeah. No,
Yes.
we're in the second portion.
Second portion.
Yes. So what you do is go ahead. What's that?
Looks like PD.
Okay, so if you have PD, what do you need to do to look for bile duct?
So I'll pull back
Okay.
clockwise.
So imagine your probe is in me. Okay, this is my probe. This is second portion. When you go clockwise, you're going anteriorly.
Yeah.
Anterior is the uncinate. So as you go anterior, you see the uncinate. As you go counter, first thing you'll encounter is the PD. Keep going counter, and you'll see bile duct. It's good to have a bit of a mental sort of view of what happens, but the probe is up against the second portion. Anterior is uncinate, which is clockwise, and counterclockwise takes you posteriorly. So you get PD first and then bile duct. So if that is PD, why don't we bring the pancreas more to 6 o'clock? So relax your a tiny bit. It's a big wheel. Relax. Okay, so that's your uncinate. Okay. Okay, so you're at kidney, right? So now go counter. Keep going counter, keep going counter, keep going counter, keep going counter. The main thing what happening is you're too
Stiff.
stiff. So you're gonna relax and be willing to fall back. So pull back the scope, relax the big wheel. Relax your big wheel, pull back the scope. Maintain that PD, okay? So pull back the scope. That PD right now, which is, where's the cursor? Don't do anything other than just pulling back. Don't spin around. Just relax. Keep pulling back. Bring this guy to about here. So relax your big wheel and keep pulling.
Okay, now.
Clockwise. Don't do too much big wheel, okay? Go clockwise. Okay, good. That's your duodenum.
That's your
right? So that's how far we were. Now relax. Now go counterclockwise. If you have unsnit, you need to go counter, right? Again, you have tension on it. I can tell just by the appearance. So relax that big wheel. Too much big wheel is a problem. Pull back the scope. Pull it back. Good. Counter. Big wheel towards your sections. Yeah, there you go. Okay, there's your PD. Yes.
Sorry.
Go
but,
counter.
What about the big wheel up and down?
Yeah,
In this
that's
position.
I guess
Going
relax your
to the
big wheel
right.
is big wheel away from you.
Yes.
Yes, sorry. So big wheel away from you, which is my way of saying relax. Big wheel away from you. Good. And now go counter some more. Okay, pull back. Here's your bile duct, glimpse of your bile duct. Okay? So, okay, now big wheel away from go counter. Okay, let me just show you just for a second. Just for the biggest issue here is not that you don't know what to do, it's you not letting go of it. So here, firstly, I always like to look at it endoscopically. So when you just a gentle amount of big wheel towards me, and again, I do this thing with the U-turn on my scope and go clockwise like this. I'm using my shoulder. Counter like this, okay? And this is what I was trying to make you do. PD first, and if I have PD in the middle-ish, around 5, 6 o'clock, if I go counter more, there will be bile duct. In this patient, you do get air artifact, but I'm just having to do a bit more bile ducts, a bit more big wheel towards me. So there's bile duct. As I go clockwise, I'll see PD. If I feel like it's falling, I have to support it with my right hand and be willing to push it forward so that I don't fall back. And if I keep going clockwise, that's my unsnit, right? And those are my mesenteric vessels. But the main thing in the second portion with these structures is you have to have a small amount of pressure on the big wheel, and then you just do gentle back and forth. So I'm doing back and forth. So PD, go counter, get bile duct. If I wanted to follow bile duct, keep going counter. But this is also where you'll fall. So to try and avoid falling, I may push forward, go clockwise again, and there's my PD. Now I'm following the PD from the head down towards the dorsal. Freeze करें एक second. Image freeze करें.
This is also a good position where you can sometimes see the pancreas divisum.
Exactly.
You know, pancreatic duct going.
Yeah.
Rather
So
than going towards the ampulla going up.
Absolutely. That's why I was going to show that this is the pancreatic duct. The dark cut portion here is the ventral pancreas.
Yeah.
This is the transition to dorsal. So if I can follow the duct from the major up here, this is your portal vein. Around the portal vein, that tells me that this is not divisum. In the setting of divisum, what will happen is the duct will stop around somewhere here, and as I go clockwise, I will see the minor dorsal duct up here, and it will go up this way because it will be in the dorsal of the dorsal part of the pancreas. So that's one way, as Dr. Sadhna said, to look for the for divisum.
So if I can you just go through that again because your voice quite got we lost your voice. I'm
Sure.
so sorry.
No problem. So can you hear me right now, though?
Yeah, very
Okay,
very
good. So I'm going to freeze it again, but as I freeze it, I just want to do this for a second. So here is the ventral pancreas. Ventral pancreas is dark. This is the transition between ventral and dorsal. This is dorsal pancreas, which is bright. So in non-divisum conventional anatomy, you will follow the pancreatic duct crossover from ventral dark to dorsal bright. And you will see the PD go up and around the portal vein like this. In the setting of divisum, this will stop about here somewhere, even shorter. And instead you will see the duct here and going into the minor, and it'll always be in that bright dorsal pancreas and go up this way. The maneuver to look for divisum is if you are looking at the bile duct here from the second portion, you just go 90 degrees clockwise, you would see the duct from the dorsal going into the duodenal wall. Here, in fact, what you see is the ventral crossing over from ventral to dorsal, which is telling you that this is not divisive. And then you can follow this duct. Here, it gets compressed by the probe, so sometimes you lose visualization. But and you'll see there's the duct now, right there, where the arrow is, coming across nicely over the portal vein. And now we can drop back into the stomach, and we can follow the duct over the portal vein, around the confluence, and into the body area. And there's the pancreas, and we're basically following it all the way from the major papilla all the way back now towards the tail of the pancreas. So there's the PD still following it along, and essentially looking, that's a nice view of the pancreas. It's a pretty healthy looking pancreas, by the way. There's the duct, there are no strands foci, a bit on the high, slightly fatty appearing pancreas, which is not very uncommon in the US, but less common here. And I'm just pulling back slowly, keeping the duct. The idea here is to keep the duct as your target. So you're keeping the duct in view, and you're trying to follow the duct all the way back towards the tail of the pancreas, which this is the tail. I'm still going clockwise. There's the duct. And at some point, I think I will use it here because it's up here. As I go counter here, now that I've lost it, I can see spleen. This may be a spleen. You can see this is splenic tissue in here, and then on the rear pole of it. I don't know if this is communicating. If it's communicating, obviously it's just a little extension. But if it was completely separate, then you would call this an accessory spleen or splenule. To the left of it, as I push in and go counter, you will see kidney. So that's the left kidney. And if you can see the left kidney, you pull back on the kidney. And if you go counterclockwise on the kidney, you'll get the left adrenal, which is this guy here, right there. This is your left adrenal. And that's what will have the seagull sign, because it usually has a little head there, and you have the two wings of the seagull. And once you have the left adrenal, if you go counterclockwise, you'll get onto the aorta and the celiac artery. So you have options for evaluating different structures from various approaches. And if you keep going on a single swoop, you went all the way from, you did most of your exam, right? The only thing, other thing I wanted to show you, and Dr. Junaid showed us earlier from the bulb before you came on, is the intrahepatic stone situation. So here I'm going back into this dual bulb. In this case, it's easy. As we get in, we right away land on the bile duct. But as I was saying earlier, what I like to do usually in this setting is drop my left hand and keep going counter. You can see that the bile duct wall is a bit enhancing, a bit thickened here. And as we kept going counterclockwise, you can see right here, there's like stone debris, shadowing stones in the ducts. So she may need a repeat ERCP if she's symptomatic. And then the only question is, why is she like getting recurrent stone disease, which happens, in some patients even despite sphincterotomy, and I don't know if she would benefit from ursodiol. I don't know how common that entity is here in Pakistan and how you deal with it, Dr. Saad.
I mean, our experience is not that common. I mean, the first thing that crosses my mind is if we completely clear the duct.
Right.
I assume she doesn't have a gallbladder, but
Yeah, she's post-coli from 2008.
the walls of the, obviously because of the stone and I'm sure infection, the walls are a little thick.
A bit enhancing, I think, yeah. But diffusely, like, the diffusely enhancing, it's not
Yeah.
irregular in nature. Name doctor magnify करना चाहिए. This is pretty much it. In the interest of not wasting time, I think I'm going to just. Can you go back a second?
Like that. Yeah.
Okay, let's give a speech. What I do is I usually visualize the fibula and just pull back a bit clockwise like this. This is I have my end of view on the fibula. I'll pull back a tiny bit and just do big
Look towards me, and usually you're on the uncinate. And there's your PD. And keep the big wheel not too tight, okay? And just gently clockwise, counterclockwise, looking for your two depths. Okay?
and be ready to push in if it's like the unstable scope position. So I'm going to hand it to you here.
Big wheel towards you. Drop it down. So we're just quickly, we're running out of time, but Dr. Jay is just going to look for that second portion view. So there's your pancreatic duct.
Pancreatic duct.
So now you have to go counterclockwise for bile duct. That's clockwise. Go counterclockwise. Or left. Yeah, there you go. Keep going. Keep going. Keep going. It's okay. Keep going. Keep going counter. Keep going counter. And you have to pull back a tiny bit for this, for her. No, actually, that's the bile duct there now, right? So remember, you're compressing it a bit. But if you don't compress, you may fall out. But if you wanted to follow the bile duct, you'd have to go keep going counterclockwise.
That's the
Yeah.
CBD.
Yeah, CBD. And if you go clockwise, you'll see the PD. There. This is your PD, right there. And in order to see it better, you have to relax your big wheel a tiny bit. So, big wheel away from you. There. And now you're following the PD
Yeah, that's the BD.
going up towards the pancreas. Yeah, good. So keep following it. There you go. Good. Keep following it. Good. That's it. Keep pulling it back. And was it clockwise or I think it was clockwise? There you go. Keep pulling back. And there's the pancreatic duct. Yep, right there. And now we're compressing it, but it does get compressed here on the pullback. But keep pulling back. That's your portal vein below, so relax your big wheel so you can see the duct. We're just compressing it a bit. Okay, here we fell back into the stomach, so now you usually have to go counter here. Get back to. Now go clockwise again. It's like, I'll go all the way counterclockwise. So you have to kind of do a clockwise counter depending on where you end up with the fallback. But your pancreas is going to be up here, right? So keep going counter and pull back. There you go. And that's your pancreas coming back into view. So there's the PD going down again. There's your confluence. Good. And now you can go clockwise. Okay, this much you've done before, right? Okay. So, yep, that's the PD. Keep pulling back. Good. Keep pulling back. It's a very bright pancreas section. Usually we see this there, but you reduce the gain a bit, but
So
that's still the pancreas and PD. The problem is the peripancreatic fat and the pancreas merge together, so it can become hard to see, but that's where you're losing it, and there's your spleen. Okay, good. Pull back. Keep coming out. Let's go to the mediastinum. So in mediastinum, you just want to go back to counterclockwise and pull back. So there's the aorta. Good. Keep pulling back and show us the mediastinum. Good. Good. Keep coming back. Liver. Keep pulling. In the mediastinum, you do have to decrease your zoom or depth because the structures are, the heart obviously is a bigger structure. So that's trachea wherever you have it, or aorta. Good. Pull back. Pull back. That's IVC going into the heart. Keep pulling back. Now go. Now you have to spin clockwise a bit. Hey, let me just demonstrate the mediastinum for a second. Stop. Okay, good. Here, essentially, what you do is you're looking. You see, the heart's obviously much more magnified, so you have to reduce your depth. But that's here, your left atrium, going into your left ventricle, and here is your aorta. This is your pulmonary artery, so you just pull back a tiny bit, and you just spin around and you will see the subcranial window, which is this. And so there's always some sort of a node here, usually small, nothing major here. That's your aorta. And the way I was taught EUS was that you should be able to do a 360-degree turn. So if you're here at left atrium, you should be able to go clockwise all the way across aorta, aortic reflection, and back to left atrium. Then you pull back a bit, and you can now go the other way. So you do a complete 360 evaluation. As you pull back, this is shadow. You can see the rings. As you pull back, the patients may start coughing a bit because they get stimulated. And when you see the aorta right there, and you see the arch, usually when you have that arch, which as you can see, because the aorta is ending to the left of the arrow, you do big loop towards you and go clockwise, and the pulmonary artery will be to the left, and aorta to the right, and that's your AP window right there. So you get a bit of a view of the artery, but pulmonary artery, but this is it. And then you just pull out. Okay? So basically, just intrahepatic stones, repeat ERCP, no mass lesion. Okay, thank you.
Thank you, Mustafa.